Good afternoon and welcome to the fifth webinar hosted by the Think Bigger, Do Good policy series. I am Thom Craig, Director of Mental Health Program for PEGS Foundation, and I'm excited to serve as moderator for today's discussion on housing is mental health care, policy recommendations for scaling housing for individuals with mental illness. The Think Bigger, Do Good policy series is a collaborative initiative by the Patrick P. Lee Foundation, PEGS Foundation, Thomas Scattergood Behavioral Health Foundation, and the Peter and Elizabeth Tower Foundation. Our goal is to help solve the growing behavioral health needs in our country by advancing public policies to transform and deliver in the delivery of mental health and substance use services. There are over 20 papers in the series covering a range of topics, including peer supports, criminal justice reform, and housing. And we have a team of national experts helping us identify the most pressing policy issues at the local, state, and federal levels. To learn more about the policy series, visit thinkbiggerdogood.org. In addition to the funding partners, I would like to thank Psychiatric Services for publishing our papers and helping raise awareness of these policy issues. I would also like to extend a special thanks to Allie Ferguson of the Scattergood Foundation, who serves as the project manager for this series. She keeps us all on track, as you can see. Before I introduce our speakers, I want to cover a few housekeeping items. First, today's webinar is being recorded. All participants are muted, so we invite you to share your comments and questions in the Q&A feature on your screen. We will be monitoring the questions throughout the event and try to cover as many as possible. At the conclusion of the webinar, we will email a recording of the presentation along with resources from the discussion and the related articles. So now, let me introduce our two incredible speakers. First, we have Sally Luken, president of Luken Solutions. She works with organizations and governments to solve social problems in the intersection of housing, homelessness, behavioral health, and criminal justice. Sally is the housing consultant for Stepping Up Ohio, part of a national initiative to house and reduce jail days for people with mental health disorders. She is also past Ohio director for the Corporation for Supported Housing. Sally was instrumental in the development and opening of the $1.2 million Adam Amanda Mental Health Rehabilitation Center here in Ohio and helped raise nearly $12 million for mental health housing in Ohio. As a former federal HUD technical assistance provider, Sally trained and assisted over 20 communities across the country end homelessness. And she's been a great help to us at Stepping Up, as well as we have regular meetings with counties. She holds a bachelor's degree in social work and a master's in public policy and nonprofit management from The Ohio State University. She wrote the paper, Policy Recommendations to Address Housing Shortages for People with Severe Mental Illness, which you can find in that thinkbigger.org, thinkbiggerdogood.org. Next, we have Jennifer Mathis, the Deputy Legal Director and Director of Policy and Legal Advocacy at the Bazelon Center for Mental Health Law, where she engages in litigation and policy advocacy to promote community integration of individuals with mental disabilities, other non-discrimination work. Ms. Mathis conducted litigation involving ADA, Section 504, and Fair Housing Act and Title 19 claims. She helped coordinate the amicus briefs filed with the Supreme Court in the case of Olmstead versus LC. She also served on the team of disability community negotiators who worked with the business community to craft what became the ADA Amendments Act of 2008. Ms. Mathis holds a JD from Georgetown University Law Center, an MA from New York University, and an AB from Harvard University. She wrote two of the papers in our series, Housing is mental health care, a call for Medicaid demonstration waivers covering housing. And the second one, Medicaid institutions for mental diseases, IMD exclusion rule, a policy debate. Jennifer, we are really glad to have you with us here today as well. So this is a big topic. So Jennifer and Sally will get us started with a few slides to just give us some context. Jennifer?
Great, thank you. So this slide is about the social determinants of health. One's lived environment includes housing. The importance of this slide is that housing is one of the key social determinants of health. That is one of the conditions, economic and social conditions that influence people's health status. So whether somebody is housed or not has a significant impact on that person's physical and mental health. Not that long ago, most mental health and disability service systems used to say, we don't do housing, we only do services. But that has really changed as the data has consistently shown us that housing is very much a necessary component of health and mental health. And the people who don't have stable housing tend to have frequent emergency room visits and a host of physical and mental health issues that come from being homeless. For people with psychiatric disabilities, being housed is not only important for people's sense of well-being, their ability to maintain social connection, participate in their communities, and to get and keep a job, but one study after another has shown that it also reduces hospitalizations, emergency room visits, substance use disorder admissions, and overall healthcare costs. And yet, housing is largely unavailable to people served by public mental health systems unless there are housing subsidies to make it affordable. If we could move to the next slide, I don't know if I can do that. Okay. So the next slide is about priced out. Every 2 years, the Technical Assistance Collaborative in Boston and the Consortium for Citizens with Disabilities Housing Task Force put out a report called Priced Out, the Housing Crisis for People with Disabilities, that looks at housing prices around the country and essentially shows how SSI or supplemental security income benefits stack up against those prices. And for many years now, Priced Out has made clear that housing prices are significantly beyond what people who receive SSI, like most people in public mental health systems, can afford. So as a result, most state mental health systems now recognize housing as an important part of their service systems. You can see from the priced out slide that SSI, this is from the last priced out report, I think it's for 2021, SSI income, which is supposed to cover all living costs, including food, clothing, shelter, and other expenses, is less than $800 a month, whereas the average rent for a one-bedroom apartment, and this is looking across the country, this is on average, some places it's much more expensive, is over $1,000 a month. So clearly there's a disconnect, and without a subsidy, people aren't going to be able to get housing. So it is good that most mental health service systems now recognize that housing is part of mental health care, but the money needs to be there to cover the housing subsidies. And many mental health systems still rely primarily on federal housing subsidies to finance housing for the folks that they serve. Some mental health service systems have their own housing subsidy programs or access housing subsidies from other agencies within the state and rely on those in combination with federal subsidies like housing choice vouchers, Section 8, continuum of care, and low-income housing tax credits to provide housing for folks in their service systems. But those housing subsidies have never been anywhere close to sufficient to meet the need for them. This is sort of the main point that Sally and I are both trying to address. They're insufficient to meet the needs for people with psychiatric disabilities or anyone else. So as a result, large numbers of people served by public mental health systems either end up stuck in institutional congregate settings when they could be served in their own homes if they could afford housing, or are cycling between shelters and emergency rooms and psychiatric hospitals at a significant cost and not a life that anyone deserves. So I will turn it over to Sally.
Thanks, Jennifer. Since housing can be complicated, and I was looking at the folks that are tuning in, a number of you are with mental health agencies, and maybe some of you know this, but we thought, again, just as a basis of understanding this complicated thing called housing, for folks with disabilities, you really need what we call the 3 legs of the stool to keep things balanced and to not only give people opportunities, but to help them remain successfully housed. And the first one is capital. So you have to have some source of money that will help you acquire land, build, to actually create the units if they don't already exist. And we all probably understand that in this country, we have a severe affordable housing shortage. So you have to have some new sources of capital to build new for this population. The second leg of the stool is that operating subsidy, the rent subsidy that Jennifer was just describing, to fill that gap between what someone's income is and what the cost is to even be able to rent something. And as Jennifer pointed out, we also have a shortage of those, especially for folks with disabilities, from my point of view anyway. And the third leg of the stool, to keep everything balanced and to really be helpful to folks with mental health issues, is the services. And Jennifer certainly knows a lot more about this than I do, but I have a friend who is now a HUD official, and she often said, if you've seen one Medicaid program, you've seen one Medicaid program. There is inconsistent delivery of the support services that a person needs to remain independent. So we say that they're going into independent housing in some fashion, but in fact, most folks with mental health issues need some level of service supports. And some of those include housing related service supports, like being there when there's an issue around the lease and you need to have a go-between with the landlord and the tenant, who may clearly not even understand that they violated the lease. And then you need all of those other healthcare services. But I really want to emphasize that the feds have said that housing is healthcare by claiming it's a social determinant of health. And so all 3 legs of these of the stool need to be in place for someone to be successfully housed and to maintain a recovery. Next slide. So this is just a view of one particular program. In my Think Bigger, Do Good paper, I analyzed the 811 program, which is a federal program that was created many, many years ago and has evolved and changed over time. But its intention was to create affordable housing for people with disabilities. And in looking at the number of people with just mental health issues that need housing, if we look at the point in time counts from the homeless system, if we look at estimates of folks that are incarcerated in jails and prisons, who may be in other institutional settings like hospitals, and not even counting the people that we all know is living in mom's basement because there is no place else for that person to go. The numbers could be close to 1 million people or more. The problem and challenge around knowing the numbers is we don't have a database. We don't have a national methodology of counting or acknowledging what the need is. And in the housing world, we usually start with what's the need. And data usually drives that. How many people are we talking about, so that we can then analyze what are the number of units that we need and what kind of units are needed to then get to the financing of those. So if we just assume that there's maybe 1 million people with mental health issues that really need some sort of healthcare in housing, the production of this one program, the federal program 811, it produces about 1,100 units a year. And my perspective is that's paltry. That's never going to get to the folks that need it. And so therefore we need a federal policy that really prioritizes and targets this population so that they can get the health care that they need. And that was our slides for right now, just to start the conversation, Thom.
Thank you, Sally. Jennifer, I was wondering if there was a way that we should look at the prioritization of these federal housing programs in terms of the particular kind of disability group or the severity of their disability. Is there a way that we can do that without violating the law?
Well, that's a good question. I think if you had, if you had sort of a separate law that required prioritization of one group, then, arguably, I think you might not run into a problem. I think there's a lot of complicated discussions that HUD has had about prioritizing people with different types of disabilities. And I would say that, aside from sort of the legal issues, there's just, there are also other issues, political issues, and just fairness issues. I think it's a little tricky. I think some of the disability services programs, they have put priorities in certain ways. Like for 811, HUD has often prioritized people coming out of institutional settings or at risk of going into institutional settings. I think that makes sense. They haven't prioritized specifically, one group of people with a particular type of disability. I think certainly HUD's view is, I think that there are Fair Housing Act concerns when you do that. I think there are potentially ways to do that, but in any event, there are certainly practical issues to it. There's a lot of people with disabilities that need housing. There are a lot of people with disabilities, physical disabilities, intellectual disabilities, who are either stuck in nursing homes or on waiting lists and not getting anything, people on waiting lists for services for people with intellectual and developmental disabilities. And so I think it is, there are a lot of complex issues, is what I would say, about prioritizing one particular group over others.
Sally, are there creative ways that we can help communities sort of make sure that, especially those who are the most likely to be in peril because they have no housing, because they need all of the supports and the housing working together, is there a creative way that we can help communities think about that and still, I guess, reach some of the ones that are most difficult maybe to house?
So it's as Jennifer said, it's complicated, and you've got those three legs of the stool that have to be addressed at the same time, from my point of view. And the service supports, if you just even start with that, landlords, property managers want to know that someone's going to be there if there's a crisis or an issue. And so local communities really should be collaborating across disciplines and bringing all the services to bear as they can. And I think they need to prioritize. this population. We're talking about close to 1 million people that are really ill and are costing the public funds in these other systems and not getting better. So that's one, is the collaborations. On the rent subsidy piece, there are some existing ways to encourage local housing authorities to prioritize folks, or to find short-term subsidies that will then carry a person through the waiting list until they get the final one. And on capital, the 811 program in particular that I analyzed in my paper, the evaluators of the 811 program even came back and said, people with mental health issues are not getting in to these units. And I understand that, why it is, because they have challenging backgrounds. They haven't always had the best track record in being a tenant. Their health needs can be episodic and create situations where maybe services can't be delivered quickly to deal with an issue. And I would respectfully counter some of the things that Jennifer said about the issue that HUD says they can't prioritize easily this group. There's actually a paper written by HUD officials about this issue that says, HUD could, if they wanted to, prioritize this population in different ways. The administration could issue an executive order to prioritize this population. Congress could prioritize this population. And my argument is, why aren't we doing that? I think we are, and I even use this word, I think we predestine people with serious mental illness to not having a significant health care delivery that they need, and that's housing.
Very good. I think that one of the things that I've often wondered, I have a brother who has autism, for instance, lives in a setting where the housing is provided by an independent, sophisticated housing group. I mean, that actually works hard to provide housing for people who have developmental disabilities. And I often wondered if, especially because of how disorganized people's thinking is when they're mentally ill, how they can still have a hard time signing up and obtaining and retaining housing, how some of the same kinds of programs that have helped, for instance, the developmental disability community set up sophisticated housing solutions could be used to set up housing solutions for people with mental illness. And I just wondered if there was a way to help communities do some of those kinds of similar things.
Well, I think the challenge with housing is the biggest financial player in housing is the federal government. In any of those legs of the stool, the federal government drives a lot of the policy and the use of the resources because they are the source of most of those resources. And so therefore, I argue that we need a federal policy that says we're going to get at this and we're going to stop allowing people with a serious health issue from spending time in jail when they went to jail because of their health issues. So local communities can do things, certainly, to collaborate and work together. And we've talked about those, Thom, in Ohio, like the 811 programs that exist right now, those 811 subsidized apartments that are in just general affordable housing apartment complexes in Ohio. Our community of mental health providers don't even know about them. And so they are not lining their folks up to get into those units. And there are challenges around that because sometimes you need a unit now. You can't wait until one gets built. But I think that if local communities just knew more about what the resources are right now and really collaborated, like what happens in the homeless system. I mean, the homeless system has evolved over the years to prioritize folks, to almost force local collaboration for the money that's available, again, from the feds. And I really believe that we need a federal policy that expects that same sort of thing at the local level for people with mental health issues.
Jennifer, does it look like there's any possible federal policy or federal legislation that might be being considered, or are there other ways that we can especially protect some of the most vulnerable in our society from like all being stacked up in a homeless shelter, for instance, where it's not really meeting their needs and they're just, caught in kind of a limbo where they don't have a permanent place to live, and it's hard for them to get into their recovery routine?
Yeah, no, that's a great question. And I think that certainly during the last year or so, we've seen a lot more federal money appropriated for housing than we have in a while because of the response to COVID and those concerns about the need for housing, both the need for people to keep the housing that they currently have and not lose it, given the impact of COVID on people's jobs, et cetera. So there was certainly a lot of money put into emergency rental assistance to help people stay housed. There was, certainly new money for housing subsidies through a variety of these programs, mostly not 811. There was not the amount of money that went into the 811 program was tiny compared to all of the more mainstream housing programs, which can be used for people with disabilities, but can also be used for everybody. And so I think that I would say this past year was sort of the bellwether for, kind of what it looks like when Congress actually pays attention and cares and, devotes a lot of money to housing. And I'd say it was still pretty tiny overall in terms of matching the need. But for people with disabilities, it is really challenging to get access to those mainstream housing vouchers. And actually, I shouldn't use the word mainstream housing vouchers because that has multiple meanings, but to use the sources like housing choice vouchers that are open to everybody, section, what used to be called Section 8. There are other programs that are broad that are open to everybody. Low income housing tax credit programs may help people with disabilities. They also help other people. The things people have tended to focus on, the housing funding streams that are disability specific, like the 811 program, because it guarantees that the housing will be available to people with disabilities. But as we saw, the funds that were appropriated were pretty small for 811 at a time when Congress was appropriating, more housing dollars than it usually does. So I just think it shows you the challenge that we face in terms of actually getting adequate appropriations of funds to meet the housing needs that are out there for people with disabilities, let alone for everybody, from Congress, even at a time when there was heightened awareness of, how challenging those needs were.
How would you say that the American Rescue Plan offered relief for people with the more severe mental illness kinds of needs? Or was it just so generally delivered and not necessarily as prioritized, so that, especially because I think we know that during this time of COVID, that many of our people with mental illness have been really affected in very negative ways. I just wondered if you've seen any special, like for instance, vouchers that would also be delivered in programs that would include services, that would include the help to get signed up in how it's so difficult to sign up for it, those kinds of things.
Yeah, and so certainly, I know there are interagency efforts now that are trying to pair, HHS is working with HUD to try to pair housing and services for people with disabilities. And they're looking, I think, in particular at money follows the person states that have money follows the person programs, which tend not to serve people with psychiatric disabilities very much for a bunch of Medicaid reasons. But they're not limiting their efforts to people who are eligible for money follows the person. They're just using those states as sort of their guideposts for places that they thought would be good for collaboration. So, there has been some effort to do that, just as there has been in past administrations. I think the American Rescue Plan itself, I'm not sure that it offered much that in terms of housing subsidies that were specifically targeted to people with mental illnesses or other disabilities. There was about $27 billion, I think, that was divided between emergency. It was mostly emergency rental assistance that enabled people to stay housed. And there was also some money for emergency vouchers. Now, some of it could be used for people with psychiatric disabilities. I'm not sure how much actually was. But it was not sort of the money that was generally targeted for the most part at that group of people, and certainly, at homeless folks who were cycling in and out of hospitals or unstable settings. There were a lot of service dollars that were in the American Rescue Plan that were useful for people with psychiatric disabilities, including home and community-based service dollars that included community mental health services and, also other sort of mental health block grant money, et cetera, but not a lot of housing dollars that I think were specifically allocated or were likely to get into the hands of folks with psychiatric disabilities.
I was going to just add to that in the American Rescue Plan and some of the vouchers, there was an allowable amount, not a lot, that could be used for some sort of tenancy support kinds of things, whether it's outreach to folks, helping them apply, that was attached to the rental subsidies. But as Jennifer said, it didn't necessarily mean that people with mental health issues were going to get prioritized. It did require, though, that, again, local homeless continuums of care work with their local housing departments, their state housing finance agencies to figure out ways to prioritize folks. And most of that, again, was geared towards anyone in the homeless system through their coordinated entry processes, which, again, are federally mandated because of a federal policy. They are not all the same or as well functional in different parts of the country. But again, it goes back to the feds required local communities to collaborate in certain ways and to talk to each other around homeless populations. Some of our folks with mental illness will get captured in that, but it's not specifically for them. And this fact that the ARP and all of these resources came about because of a health crisis, COVID, my argument is we have a health crisis, and it's for people with mental illness. And that should be generating. Because you have all of these folks across disciplines that are feeling that health crisis for people with mental illness, whether it's the local sheriff or the probation officer or the mental health case manager who's got way too many cases to handle and have people that have high needs. I mean, people with mental health issues are hitting all kinds of systems, and that crisis, I don't think, is being addressed enough in terms of housing as healthcare.
One of the things that we find ourselves doing as a philanthropy is supporting a lot of these housing agencies that work with landlords and help people get lined up and into safe and affordable housing. And one of the things that I wondered about, if you could, Sally, describe maybe the why it's good business, or how it can be good business to take care of some of our sickest people in our communities, and maybe some of the ways that we can encourage landlords to be willing to take on that risk of serving someone who may end up at times not being able to maybe in the hospital and then back, or have other kinds of issues. How can a community, I guess, make it better business in terms of how they serve and take care of people with mental illness?
Well, you know, the research is out there that demonstrates, and Jennifer even spoke to this earlier when we were talking through some of the slides. There's already evidence that shows if you provide the type of housing and the level of support that someone needs who has serious mental illness, it actually works better for everybody. Not only that person can obtain and maintain recovery, but other systems feel the effects, whether it's reduction in the jail population, whether it's reduction in hospitalization, emergency use, and a greater use of primary care out in the community. I mean, there's lots of research out there. And some of the work that we've done in Stepping Up Ohio is to actually look at a couple people and try to analyze what are they possibly costing local communities in terms of their cycling in and out of their systems and not getting better. And we've come up with some estimates, you know, of hundreds of thousands of dollars that are being spent in a way that's not productive for the systems and is certainly not good healthcare for the individual. And I think the famous one that was probably written 20 years ago by Malcolm Gladwell, and I'm sure some folks in the audience are familiar with it, it's the $1 Million Murray story, a gentleman in Las Vegas that clearly was not getting better, cycling in and out. And someone analyzed what his costs were, and it was $1 million. So the $1 Million Murrays exist everywhere. And so local communities, I think, again, back to the collaboration and talking to each other, you know, there's some simple, you know, you can even do it on the back of an envelope estimate of what their $1 Million Murray might be costing them. And and we've got evidence, again, of communities that across systems, one in our state of Ohio, the team that addressed Brent, and I will say his name because he's allowing us to use his story, it included the fire chief as part of the team because Brent had been a fire setter. And so I think local communities need to think that way and really work closely, find their $1 Million Murrays and see the success that can come from that local collaboration. And then put pressure on Congress to give them the resources that they need to help these folks.
Jennifer, is there anything you'd want to add to the business case or why it would be in our favor to support some of these kinds of programs?
Yeah, I mean, I guess I would say I agree with Sally. There is absolutely a business case. The business case is clear that it saves dollars to have people housed. And there were some interesting studies about people who were homeless. Dennis Culhane did one of the big ones in New York, but there were other ones in a variety of places. And basically, you know, having people be homeless and bouncing around between shelters and jails and emergency rooms, and having a lot of particularly physical problems, as well as sometimes psychiatric crises, costs a lot of money, so much so that, it does not cost more to actually provide supported housing to those folks. But I think part of the problem is that Congress doesn't kind of see that same cost analysis that way, because Congress is not saving money in the end from some of those things, or it's indirect, I suppose, that the United States is saving money, but it's sort of, I think, on a state level, an easier thing to grasp. We are putting money over here, and as a result, or I guess we're not putting money over here, and as a result, we're paying a lot more over here. This is one of the reasons why I think one of the things that has been very useful and important for services dollars is the Medicaid program, because it is this federal state match, has been a huge driver in expanding services and expanding mental health services. And, particularly with the Medicaid expansion, now you have 90% federal match in those states. And so it's a lot of money. And, we've gotten to a point where, certainly over the course of my career, state and local dollars constituted a lot more of mental health services when I started, and now it is almost all Medicaid dollars. That's still state. There's a state match in there, but it's all Medicaid pretty much in mental health service systems in terms of the services, because Medicaid is such an important driver in getting states to fund things. And so, the big problem with housing is not covered by something like that. So you have to depend on, these congressional appropriations, and you're at the mercy, and they've never been anywhere near sufficient. And so, one of the reasons I proposed kind of having a Medicaid demonstration waiver to cover at least some of the housing, to start with short-term housing subsidies for, short period of time, 6 months or so, when somebody's coming out of an institution, coming out of a psychiatric hospital, coming out of jail or prison, to have that person stably housed while they can take the time that they need to access more permanent housing, instead of perpetuating the cycle where we dump people out and then they come back in, and we dump people out and they come back in, and we don't really help. If Medicaid actually were available as a resource, and Medicaid has not covered housing, I think there are statutory exclusions for certain parts of Medicaid for home and community-based waivers and home and community-based programs. There's not actually a statutory exclusion in the Medicaid rehab option, which is what funds most community mental health services. But HHS has always has always viewed the Medicaid statutes not covering room and board. But I think that there is room to do, a Medicaid demonstration waiver. I think this is a good thing. I think CMS should be thinking about approving those things, about encouraging states to apply for them, to cover those services. You can tailor them. You can, this is where I think you could also specify and tailor and prioritize people with psychiatric disabilities coming out of institutions or at risk of going into them for a short-term basis. And there actually was one waiver that did have something that looked like that was approved in North Carolina. They haven't actually used the Medicaid dollars to cover the housing subsidies at this point, but it is in there and it was approved. But I think that would really be a powerful incentive for states to start actually looking at covering those housing subsidies. And, that would be, Medicaid demonstration programs are not permanent. They're a demonstration to look at what happens and if this furthers the goals of Medicaid, and you can look at it to see if it saves dollars. If, in the end, if Medicaid pays for this, then what will happen? Will you save other Medicaid costs? And I think you will. save a lot of other costs that Medicaid is currently covering. So that's my recommendation.
Sally, what's your reaction to that?
Well, it's interesting. I remember many, many years ago, one of the first executive directors that I knew that did mental health housing for her county got so tired of us talking about piloting things. She was like, why do we need to pilot another? We already know what the solution is. Why don't we just do it? And, you know, she's been retired now for probably 15 years. And we're still talking about piloting. And I understand Jennifer's point, and sometimes we need to do that, again, to get the feds to pay attention to something, because certainly it's a lot cheaper to deliver primary care to somebody with Medicaid than to see them end up in the emergency room. And again, we've got lots of research about that. But two things that I thought of. One, and I don't know if this is true in all states, but in some states, you know, managed care organizations, health insurance companies are managing Medicaid claims and benefits. And there are several of them that get it, that if their members aren't in a stable housing environment, it costs more. So some of them are doing what Jennifer just talked about, and they are actually paying the short-term rent subsidies until the person can get a final one. They're paying for those tenancy supports that other people won't pay for because they get the cost impact. We should be lifting them up and showing them off. And this issue about Congress doesn't get it because of the silos, it's not my problem, it's not my person. I think one of the things that some of these local communities are demonstrating is they are now getting it, that Joe is everybody's person. And maybe the way we're paying for our jail is a different way than the way the housing's getting paid for, but we're all going to benefit publicly if we address this issue. The other is that because people locally have got to solve this problem because they're being left on their own to solve it, other interesting ways that people are figuring it out are arising, and the idea of a landlord risk mitigation fund. Some of those are happening in other parts of the country, and it basically says, we get it. Mom and pop landlords, by and large, are renting to the population we care about because they've got some of the more inexpensive housing, or they're willing to take one of these rental subsidies if we can get our hands on one. But they're taking bigger risks because sometimes their properties are their livelihood and their pension plan. And so we need to deliver some level of shared insurance with them to say, we are willing to share the risk with you to house somebody who hasn't always been the best tenant. And we want you to be a benevolent landlord. And so we want to give you a special insurance policy that says, we'll pay for repairs if this person has a psychiatric episode and punches holes in your walls. We'll pay for the rent if the person disappears for a few months and doesn't pay their rent. So those are, to me, really, so the managed care organization's investment, these landlord risk mitigation funds, those are evidence that local communities and states are trying to solve this problem, but they really should have the feds investing more to help them.
Yeah, and I totally agree about the managed care organizations. I think that's right. They are starting to do that. It is not scaled at this point, anywhere near scaled. And I think that's actually one of the reasons, that's one of the things we point to say, you know, Medicaid should be doing this. You've got your MCOs actually, you know, doing this because they have figured out that this actually is a good investment and this saves dollars. But yeah, and I am not a fan of pilots myself, but I think it's not so much a pilot exactly. I mean, I think a Medicaid demo program is certainly, it's statewide, it's not small, but it is the on-ramp. I think you probably could not just say tomorrow, Congress or HHS interprets Medicaid, to cover all housing or something. I mean, not going to happen, but I think the Medicaid demonstration project that happens in a bunch of states, just like they've done, I mean, they've been doing these Medicaid IMD waivers, and I think there is actually more authority. It is clearer that you could use a Medicaid demonstration waiver to cover housing under the rehab option. And so I think it is actually sort of a stronger argument to cover housing in a demonstration waiver, and use the demonstration and see, if it's 5 years. If you achieve cost savings, then let's talk about, changing how the feds view Medicaid and housing.
So it sounds like if we were talking about the local or state level, some of the policy work that we could be doing, or some of the demonstration projects we could be doing, if they were strategic to change the federal way of doing things, there might be some immediate or more immediate effect. Would you recommend some things to be done at the state and local level, since we have people representing a lot of states on the call today? What kinds of things would you recommend being done at the local and state level in order to influence federal policy change?
Yeah, I mean, what I was talking about specifically is sort of having the states, you need federal approval, but having the states actually apply for a Medicaid demonstration waiver that would target housing subsidies. I mean, we have states covering housing related services under Medicaid, just not the housing itself. When the person can't afford the housing itself, then that's a problem. And so if they said, as part of our Medicaid demonstration waiver, we want you, federal government, to cover, as housing subsidies for this group of people with psychiatric disabilities that are coming out of a jail or prison for a period of time, a defined period of time. In North Carolina, they actually allowed it for 6 months, but whatever it would be, a defined period of time after they come out, or when it looks like they're on the verge of going in, to divert people, to keep people housed and buy some time to secure more permanent housing. And that's where you pair in the federal housing subsidies that Congress needs to appropriate more of, and states need to use their own rental subsidy programs to the extent they exist. And none of those, as we said, are sufficient, but at least this interrupts the cycle, interrupts people from getting out of a psychiatric hospital or an emergency room, getting out of jail or prison, and not having stable housing, and repeating this cycle again and again and again, and allows some time to get more permanent housing. And I think that's important. And then that period can get longer if it turns out that it saves money, which I think that it would. But I think you have to start somewhere, and that would be, one thing that state and local governments could do is really, local governments banding together. The state is usually the Medicaid agency that makes the proposal, but local governments, components of states, are often the instigators and the ones who drive that state policy.
And I would say, how do we create a groundswell and again get more collaboration on this particular population? And Jennifer's part of a group of advocates for folks with disabilities in general, but why can't the county commissioners associations of this country, they're the ones that are bearing some of the brunt of this with their local tax dollars, especially for jail, where, the National Alliance for the Mentally Ill are huge advocates and are very effective, both at state and federal. I wish that there was a way that we had a groundswell of people that were willing to band together about this particular population and push both states to do these demonstrations, but also to bring this issue more strongly to the attention of Congress.
Well, thank you very much. I want to wrap up here with thanking Jennifer and Sally for sharing their expertise with us. It was a terrific conversation and complex one. I think a lot of communities just don't know where to start. But I also want to thank everyone who joined us today for this webinar. And as a reminder to all of you, we will be sending out a follow-up email with links to the webinar and the recording and related articles and resources and a feedback survey so that you can let us know what you thought of today's discussion. I'm sure that it would be people would be happy to reach out to Jennifer and Sally. We could make sure that they could ask further questions and if there's other ideas that are out there that they would like to check with our experts on, we'd be happy to do that. Also, we want to be sure to thank the thinkbiggerdogood.org. We want you to visit there and learn more about our work and get access to our papers and our past webinars. We post those webinars on that site. And from all of us here today at Think Bigger, Do Good Policy series, we hope you had a wonderful day and thank you for joining us. Thank you.